Hello everyone, I'm Dr. Priyadarshini. In this current presentation, we are going to discuss about diabetic ketoacidosis with biochemistry of ketone body production. TKA is a medical emergency and a very important topic for understanding both basic biochemistry and clinical medicine. Diabetic ketoacidosis is an acute, life-threatening complication of diabetes mellitus. It is most commonly seen in type 1 diabetes, also common in patients with type 2 diabetes under severe stress. DKA is characterized by a classical triad of hyperglycemia, high plasma glucose levels more than 250 mg per dl, ketosis, and high anion gap metabolic acidosis. Biochemistry of ketone body production. Normally, insulin helps glucose enter muscle and fat cells, inhibits lipolysis, inhibits gluconeogenesis, suppresses ketone body formation in the liver. This keeps blood glucose and ketone levels under control. Whereas, the core problem in DKA is absolute or relative insulin deficiency, along with increase in counter-regulatory hormones such as glucagon, growth hormone, cortisol, and catecholamines. The increased counter-regulatory hormones promote lipolysis in adipose tissue, increase hepatic gluconeogenesis and glycogenolysis, decrease glucose uptake into muscle and fat. Lipolysis and free fatty acids. Due to low insulin levels, hormone-sensitive lipase in adipose tissue becomes active. Triglycerides are broken down into free fatty acids and glycerol. Glycerol is a substrate for gluconeogenesis. Free fatty acids is primary fuel for ketogenesis in liver. Free fatty acids are transported to liver bound to albumin. Inside hepatocytes, free fatty acids are activated to fatty acyl coenzyme A, transported into mitochondria via carnitine shuttle. CPT1, translocase, CPT2 are the enzymes. This step is rate limiting for beta-oxidation. Beta-oxidation and acetyl-coenzyme A overload. Fatty acyl coenzyme A undergoes beta-oxidation, produces acetyl-coenzyme A. Normally, acetyl-coenzyme A enters Krebs cycle. But in DKA, oxaloacetate is depleted due to increased gluconeogenesis. TCA cycle slows down. Excess acetyl coenzyme A accumulates. This excess acetyl coenzyme A is diverted to ketone body synthesis. Ketogenesis mechanism. Hormonal trigger. Decreased insulin removes inhibition of hormone-sensitive lipase, increases lipolysis. Increased glucagon shifts hepatic metabolism towards beta-oxidation. Substrate overload. Excess free fatty acids enter the liver. Beta-oxidation produces large amounts of acetyl coenzyme A. When the TCA cycle is overwhelmed, excess acetyl coenzyme A is diverted to ketone body synthesis. Biochemistry of ketone body formation. When the TCA cycle cannot handle the excess acetyl coenzyme A, it is diverted to ketone body formation inside the liver mitochondria. The schematic diagram here shows two acetyl coenzyme A molecules form acetyl-coenzyme A by thiolase. This acetyl-coenzyme A then converts to HMG coenzyme A by HMG coenzyme A synthase, the rate-limiting enzyme. HMG coenzyme A is then converted to acetoacetate. Acetoacetate becomes either acetone or beta-hydroxybutyrate. The major ketone bodies are acetoacetate, beta-hydroxybutyrate, and acetone. Ketone detection methods. Nitroproside test used for detecting urine ketones only detects acetoacetic acid. Preferred diagnostic test is direct serum assays for beta-hydroxybutyrate. Metabolic acidosis in decay. Ketone bodies are strong organic acids. When they accumulate in the blood, they use up bicarbonate, leading to bicarbonate depletion. Loss of bicarbonate causes drop in pH, causes development of metabolic acidosis. The anion gap increases due to unmeasured anions. Formula for anion gap is sodium minus chloride plus bicarbonate. The body compensates by producing Kussmaul's breathing, which is deep and rapid breathing, occurs as respiratory compensation to blow off carbon dioxide. Electrolyte changes in decay. Even though the body loses a lot of potassium in urine, blood potassium may appear normal or high. This happens because acidosis causes potassium to shift from inside to outside of the cells. Management principles. The main pillars of treatment include intravenous fluid to correct dehydration, intravenous insulin to stop ketogenesis, careful potassium replacement, treatment of the underlying precipitating cause. Complications that occur if decay is not treated early are cerebral edema, cardiac arrhythmias, acute kidney injury, shock, coma, and death. Important example: acidosis resolves only after insulin suppresses ketogenesis and glucose enters cells. To conclude, decay is caused by insulin deficiency and excess counter-regulatory hormones. This leads to increased lipolysis, ketone body production, and metabolic acidosis. Early recognition and prompt treatment are life-saving.